very amenable to either a transoral removal or at the time you're doing your neck dissection, a transhyoid approach for which one can remove the tumor, close it primarily, and the patients will still have very good function. So I think that we have to consider all options in terms of our armamentarium, but the concept of treating oropharyngeal cancers is being lost in the United States because centers are abandoning it. And the last thing I just want to mention is this whole issue about HPV. We have to be very careful about our understanding of the relationship of human papillomavirus and oropharyngeal cancer. There is no question that we have seen an increase in incidence of oropharyngeal cancers for which we totally don't understand yet. That is the one cancer in the head and neck area that's going up in frequency. And we know that there is a greater number of HPV found in oropharyngeal cancer than oral cavity. But if you do studies and you look at just paraffin-embedded tissues, or you look at frozen tissues, or you look at the technique for identifying viruses, it's going to vary and it's going to be higher from series to series. We just completed a study at our institution looking at human papillomavirus DNA and looking at the incorporation of that viral particles into the cancers as one sees in uterine cervical cancer, where you can take the DNA of human papillomavirus and find that DNA embedded within the uterine cervical cancer. We failed to show that in any of our oropharyngeal cancers. Now, it may mean that there's a whole other mechanism that's going on that's causing oropharyngeal carcinoma, but we still do not know if this is just a serendipitous finding, if it's a hitchhiker finding, if it's an alteration in role. There's a lot we don't understand yet, and we have to be very careful. We can stratify human papillomavirus in terms of certain things with outcomes, but we're not yet ready to say this is a causative factor for this cancer until we get more information.
Thank you very much, Kerry, for this very extensive and on-the-point statement. Kian, how is the management of early disease in your clinic?
Well, I think I agree with the statement that we really need to individualize treatment based on many factors, and it's well explained. And I also agree that the expertise of the treating team is very important as well. So in our hands, we treat most of early oropharyngeal carcinomas, and by early is T1, T2, and 0. I'll come to a slightly more advanced stage later on. We treat them with radiotherapy, and with the implementation of IMRT, with gaining experience of targeting and so on, we can see that the quality of life has improved quite dramatically, and the control rate has been extremely high. So I guess, Kerry, the chance of new residents learning in operating after radiation failure is probably going to even to decrease. So I guess one of the issue is now that radiation oncologists have to really learn anatomy, the anatomy as well as surgeons almost, because we can deposit radiation very precisely, and therefore learning the route of spread is very important. So we are all in the learning phase as well, and I agree with Kerry that we have to look into the role of HPV very carefully. I'm aware of protocols that has been designed already calling for reduction of therapy. I think the next step should be stratification instead of selection.
Jan,
well, I think these additions, because I have been focusing mainly on locally advanced disease, because my role as medical oncologist is restricted to that mainly. All the decision making in my hospital is multidisciplinary, and so we have patients that are receiving surgery for early stage of oropharyngeal carcinoma. But there has been also in my institute a tendency that radiotherapy is being used also in more earlier cases. And I think that what you mentioned about being careful with the interpretation of HPV is correct. That's also the reason why I said at the end of my conclusion that there is absolutely uncertainty about how you can use these data for decision making. And I think especially when we talk also about organ preservation trials, that it would be very good to stratify for it in order to learn something. And it may be so that in the future you may use less radiation or less chemotherapy for these subtypes, but at the present time that's completely unknown.
Just a remark from my point of view, and then Dr. Shah. In the Charité, we have the procedure that the early cases, T1, T2, and 0, when they have been resected with adequate resection margins, we don't do anything additive then, except we have a nodal disease where we do post-op irradiation. And in some situations with T2 where the margins are not so clear, we of course use also additive irradiation. But I think it's a very simple procedure, as you said, few days on the ward, and the patients can leave and need not many weeks of radiotherapy. And this can be spared for a later, in case there is a relapse, which I don't think, but when there is one, you have the full option of radiation to administer later on. So in the very early cases of oropharyngeal cancer, I think surgery is still the mainstay from my point. In Europe, in Germany, I know that in the States it's something else. Yeah, but Dr. Shah.
Thank you, Mr. Chairman. I think I want to clarify one issue. Oropharynx is not one disease. They may be anatomically contiguous, but these are different tumors. True. Tonsil cancer is an entirely different disease than an endophytic base of tongue cancer. And they need to be separated out. To talk about results of oropharynx cancer is equal to talking about results of head and neck cancer. We are talking about apples and oranges. You have an exophytic tonsil cancer, highly radioresponsive, can be controlled with radiation alone without any chemotherapy on and without the morbidity of concurrent chemoradiation. Quite in contrast, a T1 or a T2 endophytic base of tongue cancer is going to be radiation resistant unless you employ brachytherapy in addition to external RT. And even then, you will have what Hiltrud showed, a chronic non-healing ulceration, painful, difficult to swallow. So I don't think, Carrie, surgery is out of the gamut for oropharynx carcinoma. What the clinician needs to do is to understand that these are biologically different tumors, and careful assessment of the tumor, its location, and its depth of extension into the third dimension are crucial to selection of initial treatment.
Yes, thank you.
I would like to add another objective. Carrie also mentioned it also, and Madame Forastiere also. Our patients are more and more younger, and if you have a full dose tumor treatment with chemoradiation, what are you doing if the patient is surviving? And depending on our results, there is about 30% multicentric cancerization in the upper digestive tract. So what are we doing then? If you did surgery and you have restricted post-operative radiotherapy, then you may have the other option that you can have another radiation therapy, or you may have another possibility to do surgery. But if you have a full dose concomitant chemoradiotherapy, it's the last thing you could do. So there is nothing left for the second primary in this field. This is, and I think for younger patients, you have to have another treatment in your mind than for elderly patients. If the patient is over 70, 75, I wouldn't hesitate to do full dose chemoradiotherapy if he suffers, if he tolerates it. In our investigation, patients over 80 were excluded, and comorbidity, multiple primaries, and so on. So I think the primary in the younger the early lesion in the younger has to be treated differently from the early lesion in the elderly patients. So you have to individualize more, as Gary Olsen said that before, and there is the interesting thing is the advanced tumors. I think not the early one. The early one, yeah, is still a role, as you said, for surgery alone.
Gary?
Just a couple comments along the line with what Dr. Shah just said. I think that one of the real critical things that's important when we look at oropharyngeal cancers is the recognition that anytime you're dealing with tumors that fall within the confines of Wildauer's ring, you are dealing with many tumors that are clearly different in terms of their behavior than one sees in other areas of the upper air digestive tract. You have the location of lymphoepitheliomas, you have a higher incidence of non-keratinizing squamous cell carcinomas. But if you look at a carcinoma T-stage for T-stage and how they behave in terms of the neck, they're going to behave similar. But understanding how the tumor looks and its behavior is critically important in the assessment and management of a tumor. We all know that if you take a tumor on the lateral tongue that's growing as an exophytic lesion with minimal infiltration, that tumor is going to behave much better than someone who has an endophytic tumor that's growing as an ulcer. If you take someone who tells you that they've had a neck node in their neck for 2 years and it hasn't changed much, it's a much different cancer than someone who comes in and has a rapidly growing tumor that's occurring over a period of a few weeks. All of these things in terms of how the tumor is behaving in the individual, how its growth pattern is, what its grade is, what its histology is important. And unfortunately, if we look in the area of the oropharynx, we do have, because of the nature of the lymphoid tissue, we have different tumors found there than we see in other areas of the tongue. But if you look just at invasive squamous cell cancer, I don't think there's much difference. And that's the big thing.
Okay, I think we stop now with the locally circumscribed tumor and go to the locally advanced, where we have many data. And Kian, you have some comments.
Yeah. So just shortly, I think in early tumors, I guess we need to strive for a single modality treatment. So I think, however you select the patients, try to, if you treat it with surgery, try to select it such that we are dealing with the patients that do not need postoperative radiotherapy, because otherwise then the whole aim of avoiding radiation is become invalid. Now, may I have my slide, please? Now, I think I want to raise one question, is that do all stage 3 and 4 disease benefit from combined therapy? And Dr. Shah is chairing the staging committee here. If you look at this distribution, you can see that stage 3 and stage 4, they are a combination of many types of tumors. And we started many years ago, after realizing that adding chemotherapy to radiation is increasing morbidity, to look into the so-called small T but N-positive patients. And you can see this series dated back to 75, when either CAT scan was not used as a systematic staging, or the resolution of CAT scan was not too good. So I think many of these patients will be upstaged to N2B at least. And look at the results of radiation alone. And on the left side, you can see when the neck node is N1 or N2A, the local regional control rate with a single modality treatment is 85% and distal metastasis 10%. And the story is different when the end stage is higher. You can see the distal metastasis rate is 28% and local regional control rate is lower. And in fact, local regionally, we can do better now with IMRT. So this is a series pretty large already. We started with smaller tumors, and as we gain more experience, we treated a few T3 and T4 tumors